So it's a really great pleasure to be with everyone today, virtually at least. And my name is Zach Ballard. So I'm a postdoc at UCLA. And I'll be presenting along with Dr. Hyouarm, who won't be presenting formally in the 30 minutes, but will be around for the Q&A. We work with Professor Idawan Ozcan at UCLA in the Electrical and Computer Engineering Department. And we're really excited to be able to share with you some recent results we have on computational sensing for point-of-care diagnostics. And specifically, we'll be talking about a multiplexed paper-based system that we've developed for Lyme disease diagnostics and cardiac health monitoring. So if today's powerful computers, computational resources, and algorithms had existed before a sensor or instrument was designed, how would it fundamentally change and improve the sensing system? So I have this question here because I think it really gets at the heart of what I mean when I say computational sensing. This is, of course, just beyond the use of computers for sensing, but really looking at how sensing can inform, or how computation can inform sensing design, which is an important question engineers, I think, should ask themselves in this day and age of big data and powerful computation. And this is because sensing systems are kind of traditionally thought in a linear manner where you have some sort of transduction element that creates an electrical or optical signal in the case of biosensing, that the raw signals are then acquired by some sensing hardware, and then computation is used to interpret those raw signals to output a final result, whether that be a binary diagnostic or a quantitative result. And of course, analytical models can be used to infer the raw sensor data, but in practical applications, these are inadequate due to different confounding factors and noise factors. So machine learning has increasingly taken the burden of this task of predicting a result from raw sensing data. And I'm sure you're all familiar with machine learning. But I do mean it in the broadest sense of generating a training data set composed of the raw sensing data, along with a predictive model, and then a gold standard measurement coming from some other system. This predictive model is then trained with respect to a cost function, which I'll denote as J throughout the presentation. And then the predictive model is then blindly tested on a different data set to understand its robustness and its performance in the real world. And machine learning models take all different forms, from just simple multivariable linear regressions all the way to multi-layer neural networks that are kind of dominating now. Computational sensing really takes one step further and asks how this computation can now go and inform the sensing system itself and the hardware. And this, of course, can be done with a very well-known tenet of machine learning known as feature selection, where some number of sensing inputs, here denoted by X, are then down selected in terms of their elite democracy, if you will, or optimal subset that can result in a prediction model that is the most accurate. And this sort of process can improve the performance of a predictive model by avoiding overfitting. But it also has really big implications for sensing hardware because it can make cheaper and more compact acquisition hardware and application-specific designs. And this is really crucial for point-of-care diagnostics that rely on being low cost and easily distributed to have the most impact and to democratize healthcare. So with that kind of setting the stage, here's a brief overview of the presentation. I'll be talking about computational sensing and how it can apply to specifically paper-based assays and a multiplex paper-based assay that I'll share with you. And then the bulk of the presentation will focus on application for Lyme disease diagnostics, as well as a cardiac biomarker quantification for stratifying patients in terms of their risk of cardiac events. I'll wrap up at the end with just some brief summaries and conclusions, and hopefully have time for a nice Q&A at the end of the presentation. So the sensing system that we're focusing on today is a paper-based sensing system. And this is because paper-based immunoassays are arguably the most common and ubiquitous form of point-of-care diagnostics. They've been around for 50, 60 years, and are widely accepted largely because they fall into this WHO assured criteria, meaning that they're quite affordable. They can be very sensitive and specific depending on the immunochemistries, and are very simple to operate. They make up a large part of the sensing market, and I'm sure many of you have seen in the news recently that antibody tests or rapid diagnostic tests are quickly being adapted for COVID-19. This is different from the PCR tests that are used in the centralized labs, and that's because they can be widely distributed for epidemiological studies as well as contact tracing. And pregnancy tests, of course, are one very common example. And these paper-based tests, though being a relatively old technology, they have a renewed interest due to the advent of portable readers and consumer electronics that can very simply take an image under some sort of structured illumination and provide a user-friendly interface in which an end user can even add spatial temporal mapping features and eventually get rapid and very accurate quantitative results. And with this, of course, opens the doors for advanced computational tools to be applied to these point-of-care diagnostics. So the most common form of a paper-based test is shown here on the left. So it's known as a lateral flow assay or rapid diagnostic test. And it works by wicking a sample across the paper strip here, where the analyte of interest binds through a specific chemistry, which is typically antibody antigen chemistry. And then the analyte is then bound with an optical tag of some sort that's contained within the conjugate pad in a dry state. So this is released upon wetting and creates a color signal in the case of gold nanoparticles, which is the most standard optical tag in paper-based tests. And of course, these can use other optical signals like fluorophores. And though this is widely used and is even being adapted for COVID as we speak, this inline geometry really hinders highly multiplexed designs that can analyze and quantify multiple analytes in a single go. And that's because the analyte has to then move through multiple test lines, creating issues of cross-reactivity that can hinder the performance in a multiplexing scenario. So Dr. Zhang has worked over the past 4 years with me in the lab developing a vertical flow assay that will be the topic of today, where instead of the sample moving across a single strip, the sample moves through a vertical stack of paper. And it gets to interact with a multiplex sensing membrane that's contained at the top layer of this bottom case. And this allows for spatially isolated immunoreactions that can completely avoid crosstalk. So although the immunochemistry is the same, this different format can allow for highly multiplex sensing systems and also makes it very interesting from a computational analysis perspective. So this is kind of what that looks like with a cartoon. We have the multiplex sensing membrane. It's a relatively large area. It's 12 by 12 millimeters. And a hydrophobic barrier, in this case created by wax, can create these isolated immunoreactions. So by putting different chemistries a priori to running the assay during the fabrication phase, you can get different immunoreactions in multiplex for your different analytes, as well as understand how maybe a single analyte reacts with different immobilized chemistries. And we've taken this system and actually done very highly multiplexed immunoreactions, up to 100 reactions. Here's actually 81 shown in a 9 by 9 grid, and then here it's foregoing the wax printed barrier. But this format can allow for up to 100 different immunoreactions to take place within a single test. And there's a lot of engineering that's gone into this test, but it won't be the topic of this conversation. I'll instead point you to a lab on chip paper that we published last year detailing the adaptation and development of this system. So today I'll focus on computational sensing using this system with respect to Lyme disease and heart disease risk assessment, starting first with Lyme disease and how computation can inform the different sensing membrane designs that are contained within this vertical flow assay. So before I get into the computational elements, I just need to briefly talk about Lyme disease. It's an infectious disease, the #1 vector-borne illness in the United States, caused by Borrelia burgdorferi, which is a bacteria spread through the bite of a tick. The CDC estimates there's 300,000 new cases per year, and this is a growing number due to the expansion of tick populations. And importantly, Lyme disease can be effectively treated with standard antibiotics, but it does require a clinical diagnosis first. Here's just a map of the expanding tick populations, kind of underscoring the urgency for new technologies. And here, if you take a moment to read the comic, I think it really gets at the current state of Lyme disease testing, and that's that it's really poor. It has a very high cost, the current two-tier testing system, and has a slow turnaround time as it uses centralized laboratory infrastructure. And importantly, it has very poor sensitivity, less than 50% typically, for the early stage of the Lyme disease infection, which is within the first month. This is largely because Lyme disease is incredibly complicated to diagnose. The bacteria that causes Lyme disease is in such low concentrations in the blood that PCR is not really an effective technique. So the current gold standard diagnostic techniques relies on measuring the antibody profile in different individuals with the infection. But this is a very complicated diagnostic picture because different individuals, based on their patient history, can have different antibody profiles shown in this graph here, where the different antibodies are shown on the x-axis denoted by their molecular weight, and the percentage of patients are shown on the y-axis. Furthermore, this is a dynamic situation where, depending on your stage of infection, you may have a different antibody profile in your blood. So this is a really interesting problem with which to apply computational tools to try to create some predictive model that analyzes a large number of antibody measurements from a diverse patient population and then infers a positive or negative diagnosis from these multiplex measurements. And so that's what you can see here on the bottom right. We have the multiplex sensing membrane measuring different Lyme-specific antibodies that are denoted by the color and these funny letters, as well as positive and negative control spots that are essential for quality control and understanding the degree of non-specific binding. So using this test, we can support a very simple operation, not too dissimilar from that of standard lateral flow assays, simply adding running buffer and a serum sample with followed by another addition of running buffer for a washing step. There's then passive incubation, in which case the first top case is removed in exchange for the second top case, which contains the gold nanoparticles responsible for the color signal generation. And then this is wetted with the addition of one last running buffer followed by another passive incubation. And we can actually run multiple cassettes in parallel, one that can be entirely devoted to detecting IgM class of antibodies and IgG class of antibodies, collectively getting a relatively comprehensive look at the different Lyme-specific antibodies in a patient sample. This total assay time is 15 minutes. And once the assay is complete, it can be read with a low-cost and handheld reader that uses very simple LED illumination with green LEDs at the absorption maximum of the gold nanoparticles, and essentially takes a picture of the multiplex sensing membrane, which allows for quantitative analysis. So we achieve this by normalizing the picture of the assay after the assay is run, and normalize this with respect to a control before the assay. And then through an automated image segmentation algorithm, we can calculate the actual color intensity of the different immunoreaction spots, and then correspond this to our different spot map and generate inputs. And these inputs can now be interpreted by our predictive model. So between the IgM and IgG vertical flow assay, we can have 20 different inputs, with 2 of these being positive and negative controlled in each vertical flow assay. So this means to say that we have inputs now that are ripe for a machine learning problem. So using this platform, we worked with the Lyme Disease Biobank to run a standard machine learning problem where we were given 50 samples that we ran in duplicate to build a training data set. And it's important to note these are all early stage samples where the gold standard has a sensitivity of less than 50%. So this slide here represents the raw data from our vertical flow assay with the training set. On the left is the spot map, and an example of a sensing membrane for a given patient sample for the IgM and IgG. And on the right shows all the Lyme positive samples with respect to their different antibody measurements. Here, the color bar represents the normalized signal. The normalization here is done with respect to the mean of the negative controls. And this is a really fascinating heat map to us because it really shows there's not a single Lyme-specific antibody that can be used to unilaterally decide on a diagnostic. In fact, there's some subset, there's some ensemble of these measurements that can be made to have a robust diagnostic. And therefore, maybe a predictive model based on a training set that's data-driven can be most effective for coming up with a diagnosis. So for this, we actually implemented a deep learning algorithm that contains a multi-layer neural network. The network is trained using a binary cross-entropy function, which is standard for binary diagnostics. On the right here, I have some details of that network. So it's a relatively small network, 128, 64, and 32 nodes in the different layers. There's a rectified linear unit activation at each layer, and a very high degree of dropout to avoid overfitting. We are in a data limited scenario here due to the low number of patient samples that we can obtain. The last layer contains a sigmoidal activation with a threshold of 0.5 to determine positive and negative diagnosis. So this model can of course be trained to come up with a diagnosis, but getting back at the idea of computational sensing, how can we use the machine learning framework to also design the sensing membrane itself? How can we find the optimal subset of antibody measurements that can create an accurate diagnosis? A brute force search is one approach, but of course this creates millions of training instances that could take months to train given our 20 inputs. So instead we use a wrapper method called a sequential forward feature selection. And this is an algorithm that adds a feature one at a time to the predictive model and then trains the predictive model. After it adds all of the features, it keeps the feature that provides the best diagnosis, and then it repeats this process until all the features are added, at which point we can assess all of the different subsets of features for the optimum. So by doing that with our training data set, we have the receiver operator characteristic, which can show you the diagnostic performance by taking its area under the curve. And we can see that starting off with a single sensing input can give us very poor diagnostic results. And as we add sensing inputs into the wrapper method, we get a local optimum, and then it goes to being a poor diagnostic result as we add all the inputs. And this can be due to instances of cross-reactivity or noise of the immunoreaction. So another way to look at this is to simply plot the different area under the curve corresponding to these different receiver operator characteristics, and we can indeed find there is an optimum with with a subset of 9 different features, 3 coming from our IgM cassette and 6 coming from our IgG cassette. And this is great because not only is it an optimum in terms of diagnostic performance, but it also allows us to just leave out some of these antigens that were spotted onto our sensing membrane, which can cut down costs in our assay and also allow for another development phase where perhaps redundancies or additional positive and negative controls are input to increase the performance. So this brought down our cost per test by about half. And this is, of course, the cost per test of us buying the reagents, but at bulk, these reagents would be much more simple. But this is just illustrating the fact that this is a cost performance trade-off that we've optimized for. Now, one really important thing to mention here is that you can take a more simple approach without the use of a neural network as a predictive model. Here you could simply, for example, just filter all of the different antigen targets based off of some statistical metric like a t-score. So if you were to do that and sort the discriminative ability between positive and negative samples of each of these antigen targets, you can then select the top 9, for example, to directly compare to our wrapper method. But doing this actually results in a much worse performance. It results in an AUC of about 0.9 when compared to an AUC of 0.97 when using the wrapper method in the neural network predictive model. So although this might be an intuitive approach, our training data suggests it's not the optimal approach. And this can be chalked up to the unimportance of redundant information. So in other words, an antigen target that's associated with the same patient population or stage of infection is maybe less useful if it's already selected as a feature. And instead you want those more rare instances of indicating a patient positive that may not be representative in the population on average. So after this training and selecting an optimum sensing membrane, we then worked with the Lyme disease biobank to receive another lot of samples that were fully blinded. Here was another 50 samples that we ran in duplicate using our vertical flow assay and predictive model. In blindly testing these samples, we achieved a sensitivity of 90.5% and a specificity of 87%. Which is very competitive with respect to studies that evaluate the current gold standard two-tier method. And also important to note is that in the training phase, we can also favor specificity or sensitivity based off of the threshold in our sigmoidal output. So that's what the result in the parentheses indicate. Here where we prefer specificity over sensitivity to allow doctors more discriminatory ability in terms of ruling out Lyme disease. So these are very competitive results for point-of-care Lyme diagnostics, and we think there's a lot of promise moving this forward into the future. So now I'll shift gears and talk about another application using this computational approach to this multiplex paper-based assay. Here, instead of a binary diagnostic, we're going to talk about quantification of a biomarker that can indicate risk of heart disease. So the biomarker of interest is C-Reactive Protein. It's a general biomarker of inflammation, but there was a large-scale clinical study that evaluated tens of thousands of participants and showed that this quantifying this biomarker along with cholesterol can actually lead to better patient outcomes when deciding statin therapy. So this has led the American Heart Association to recommend 3 different clinical cutoffs for stratifying patients in terms of their risk for cardiovascular disease. These cutoffs being 1 milligram per mil, 3 milligram per liter, and 10 milligram per liter. This is a really important test because heart disease, as you may know, is the #1 killer globally and a major problem also in our country. So here we have a slightly different sensing membrane design. Instead of the 13 immunoreaction spots shown with the Lyme study, we actually are using a 9x9 grid of immunoreaction spots here and foregoing the wax printing sensing membrane to allow us to fit more immunoreactions on our sensing membrane. And importantly here, though we're trying to quantify a single analyte, we have different immuno-chemistries that can uniquely react with the CRP analyte to create different signals as the analyte concentration increases in our patient samples. So on the left is what a 0 sample or a negative control sample would look like. And then as you increase the C-reactive protein concentration in the vertical flow assay, you can see that the immunoreaction signals have a varied response. And if you look at this response plotted out, looks very interesting. We have an antibody signal that can increase with increasing analyte concentration up to a point where, due to competitive binding known as the hook effect, the signal starts to decrease. And this is a major problem for sensing because if you measure a normalized signal that's about this mid-range, you don't know if you have a relatively low analyte concentration or a high analyte concentration. So taking advantage of this multiplex system, we can actually create a monotonically decreasing signal by spotting the antigen itself that can allow us to discriminate these different regions and can allow us to achieve perhaps better quantification as we have different sources or different information channels for our quantitative model. We can also, of course, include positive and negative control spots, as well as mixtures of the antibody and antigen shown in the red and purple. So using this system, we also set up another machine learning study where we worked with clinical samples under an IRB. And one difference here with the Lyme study is that we also started paying attention to our different fabrication reagent batches. So we actually aliquoted reagents at 2 different times and then made a note of this by keeping track of them and indicating the reagent batch with an integer number 1 or 2. And then we use these aliquots on our different sensing with our different sensors, and also kept track of the fabrication batch. Fabrication batch indicates the continuous nitrocellulose sheet with which these sensing membranes were fabricated on. And for each reagent batch, we had 3 batches of the nitrocellulose sheets. And of course, our gold standard here for this machine learning study was coming from this machine shown on the right, which is the size of a washer dryer unit. And it's what's used and FDA approved in the hospital, and it's a very sophisticated instrument and very high throughput, but clearly not conducive to the point of care. So for this study, we activated over 250 vertical flow assays using patient serum samples run in triplicate. And we also spiked some serum samples to try to get samples that would be in that high region above the hook effect. And this is kind of what it looks like when we activate these in the lab, fabricating them in mass. And again, I want to point out that for each sensor, we are keeping track of the reagent batch ID with an integer number, as well as the fabrication batch ID to include as inputs to our computational analysis. So this slide is a very busy slide, and it's the raw data coming from our training data set. And I have it here because to show you how much of a mess it is. Essentially, it's not really obvious how you would use all of this information. And also what's pretty clear here is the difference between the reagent batches, which is a really big problem and a practical challenge for point of care sensors that need to be distributed. Just aliquoting the reagents at different times can lead to very different signal response, indicating that a single model for calibrating this is not sufficient. So the different reagent batches here are indicated by the blue and green colors. And then even the fabrication batches, just spotting proteins on different continuous sheets of nitrocellulose, depending on the temperature or humidity at the time of spotting, can have a systematic effect, especially in the antigen spot that is a less stable protein. We can see here that the fabrication batch 1 has a lower signal followed by the triangles and then the stars. So this is a really interesting data set with which to analyze with more advanced computational methods to achieve more accurate quantification. So to do this, we split our data set into a training and testing set with an 80-20 split, and then analyze the training data set with a k-fold cross-validation with 5 folds. And similar to the Lyme study, we're not only interested in just quantifying, we're interested in trying to inform the sensor design itself. Obviously, this is an over-engineered or over-designed sensing membrane, and we can probably just select some subset of these immunoreactions for accurate quantification. So to do this, we actually did this in 2 steps. One, we used a filter method where we just simply ranked each immunoreaction spot based off of a cost function that's shown mathematically here. This cost function is essentially the coefficient of variation of each one of the immunoreaction spots. And this allowed us to essentially rank the immunoreaction spots from best to worst, and then evaluate our predictive model, which in this case also was a neural network, in terms of how it performs with when we start to eliminate some of the worst spots. And we can find that, again, there's a minimum in terms of the cost function, the mean squared logarithmic error, and also the correlation coefficient by eliminating spots that are mainly found on the edge. This also can inform us of the sensor performance itself and fabrication bias. For example, we were unsurprised to find that the least robust spots were on the edge of the sensing membrane. We know this is where the flow can be most non-uniform, and therefore it's made sense to us that this is exactly where there is not robust performance. Also in the middle of the sensing membrane, interesting, we found that the flow non-uniformity perhaps could contribute to immunoreaction signals that have a large standard deviation across the samples we measured. So now we can reduce our spots to 38 spots. Of course, similar to the Lyme disease, we are really interested in also how the immuno-chemistries can correspond to the quantification accuracy. So for this, we used, again, a wrapper method, which is instead of a feed-forward selection, we did a backward selection where we started with all the immunoreactions and eliminated them one by one. Again, finding that optimal performance by eliminating 2 of the immunochemistries. So then just by analyzing the 28 spots on our sensing membrane and applying our trained predictive model to the sensing membrane, we first actually classify the sensing membrane in terms of acute inflammation to try to indicate the very high concentration of CRP that wouldn't be analyzed for cardiovascular disease risk. And then anything that's within the HSCRP range is then quantified again by our neural network. So lastly, the quantitative results are shown here in the blind testing set. This is the high sensitivity range for cardiac risk assessment shown on the x-axis from 0 to 10 milligrams per liter. As you can see, there's really great accuracy in terms of the quantification. Importantly, we had 100% classification accuracy for acute inflammation, essentially overcoming the hook effect due to our multiplexed immunoreactions. Without the multiplexing, these would actually be misclassified as low to mid-risk samples, which is obviously not good for stratifying patients. Of note here, the coefficient of variation of 11.2% is close to the 10% recommendation by the FDA. There is no current point of care sensor for high sensitivity CRP due to the challenge of this getting precision around these clinical cutoffs. So we believe with this neural network approach, we were able to improve the quantification accuracy, and also including the reagent and fabrication batch ID, we actually reduced this coefficient of variation from about 16% to 11%, and that's because the network can understand and start to understand the nuances between reagent batches and fabrication batches, provided they're represented in the training set. And in contrast, this is what the results are if you just use a standard multivariable linear regression to try and quantify the CRP concentration from the multiplexed immunoreactions. The coefficient of variation is much higher and leads to worse results in terms of stratifying patients. So in summary, I've shared with you computational sensing is applied to multiplexed paper-based sensors. This can allow a sensing platform to screen for optimal antigen-antibody pairs for quantification or binary results, allows us to reduce the reagent costs, and can also inform fabrication biases and opens the door for a data-driven assay development. It's also important to note that with our data sets, we found that the prediction models did not overfit, showing that we can have robust performance moving forward. We're looking forward to pushing this platform forward. We have ongoing collaboration with New York Medical College for the Lyme test, and are also working to actually multiplex, measure multiple analytes with the cardiac test. And of course, we would love to get this out into the world, and so have started a company, HANA Diagnostics, to try to further develop and commercialize this type of technology. So with that, I'd like to thank all my colleagues and collaborators, Professor Ozcan, DiCarlo, and Garner, as well as Arne Baldi and Dr. Doutweiler, and also Hyouarm, who will be available during the QA and equally contributed to this work. I'd also like to thank you all so much for your attention. I'm really looking forward to Q&A. All right, thank you so much.